everyone. Being pediatricians, we all know that growth and development constitute one of the key aspects of pediatrics. When you were preparing for your NEET PG exam, then also this was an important area. When you were in your residency, again growth and development was something you read on a daily basis, which you calculated on a daily basis. And now that you are preparing for NEET super specialty and other fellowship entrance exams, you would realize that this topic continues to be a high yielding area for your entrance exam. Of course, we'll be dwelling more into details as we had done in the earlier past. We'll be going into an MCQ oriented approach, but not losing hold of the concepts, the principles involved. And keeping this in mind, in this module, we shall be initially talking about the normal growth and normal development. Abnormal growth patterns, delayed development patterns will be taken up in the subsequent modules. So let us begin with the growth and development. Now, what is growth and what is development? You know that growth and development are normally taken into, they're talked about in same breath, but they are not the same. What is growth? Growth refers to increase in the size or number of cells or tissues or even organ systems. So whenever there is increase in the size or number of cells or organs or tissues, we call it as growth. So only numerical number increasing or the mass increasing of a particular organ system is called as growth. What is development? Development refers to maturation of functions. So when the functions mature, we call it as development. Usually both go hand in hand. So we use the term growth and development, but sometimes growth ceases after a certain degree of time, maturation keeps on happening. Just like there is a proverb that learning continues till you are alive. Similarly, development or maturation of functions continues even after growth has ceased. And that is true for every human individual. Now, the point you need to remember for your exams is that growth is usually measured quantitatively. Old statement based question on this has been asked, and development is measured qualitatively. There are exceptions to this rule, but in general, quantitative measurement is easy. It is commonly done for growth, and qualitative measurement is done for assessing development. So with this in mind, we move towards the terminology used in childhood. The terminology is very specific. It is easy, but I have seen even good students fumble them in MCQs or in Vivas. So terminology states that what is an ovum? So from fusion of the sperm and the ovum, that ovum word is used till 2 weeks after fertilization. So till 2 weeks after fertilization, the ovum, even after it has been fertilized by the sperm, is still called as a ovum. This is how the terminology is. Then you have the term called as zygote. What is zygote? Zygote is the term used for product of conception ranging from 15th day till 8 weeks. So till 8 weeks of gestation, you will call it as zygote. Third is your fetus. Fetus is the time, it is the term used ranging from 9th week of gestation till birth of the child. So till birth you will call it as fetus. Then you have the term called as perinatal period. The term perinatal period is used from 22nd week of gestation till 7th day of postnatal life, that is after birth. Then you have a newborn or a neonate. Neonate is a child who is up to 4 weeks of age. So first 4 weeks of life, postnatal life, is called as the neonatal period. It is sometimes subdivided into early and late neonatal period. where early neonatal period is defined as 0 to 7 days and late neonatal period is defined as beyond 7th day, that is 8th day to 28th day. That is the late neonatal period. Then you have infant or infancy. It is up to 1 year of age. So all neonates are infants, but all infants are not neonates. Then you have a toddler. The age group given is 1 to 3 years of age. We have a preschool age child, which is from 3 to 6 years. And then we have a school age child, which is from 6 to 12 years. Now, the important point I'm mentioning here, when you talk about the definition, toddler is 1 to 3 year and preschool is 3 to 6 years. So many students get confused. Sir, if a child is exact 3 years, is it a toddler or is it a preschool age child? If it is exact 3 years, it is a toddler, it is not a preschool age child, because if you look at the exact definition, they write it like this. Preschool age is more than 3 up to 6 years of age. Similarly, school age is more than 6 up to 12 years of age, and toddler is more than 1 up to 3 years of age. So this sign which is coming is important. To give you an example, suppose a child has his 3rd birthday tomorrow. So till today, the child will be called as a toddler. So as soon as the 3rd birthday happens, on the 3rd birthday also, the child will be a toddler. The next day onwards, now the child is 3 years and 1 day. Now 3 years and 1 day means more than 3 years, and now the child will be called as a preschool age child. So these small points can sometimes be asked to you in the exam. There is a separate classification system which talks about months instead of years. But again, this conundrum comes into play there as well. So whenever we are taking the range, the first point of starting in these terminologies, we always put greater than sign to keep it simple, to avoid any ambiguity. And finally, before we move to the next small subtopic, what is an adolescent? Adolescent period is defined as 10 to 19 years of age. This is defined by UNICEF WHO. We cannot change it. Some of the textbooks, including OP Ghai, talk about 10 to 20 years, which is not correct. Adolescent period is defined differently in different countries. Even textbooks define it differently. We are taking this adolescent age group because this is how it is defined in WHO, UNICEF. This is how it has been defined in ICMR guidelines and ICMR publications. So early adolescent period is 10 to 13 years. Mid-adolescent period is 14 to 16 years. And late adolescent period is 17 to 19 years. So this is the subcategorization of adolescent period. So this is a small topic, but questions have been asked on this and people do go wrong in terminology. So terminology in childhood. Next we come to the growth patterns in case of human beings. Now it is a potential MCQ. Remember that growth pattern in human beings is number 1, there are 2 characteristics, cephalocaudal, and second, it is distal to proximal. What is cephalocaudal? Cephalo means head, caudal means the tail end. It proceeds from up to down. So in the central axis, the growth is from top to bottom, and in the extremities, the growth is distal to proximal. Distal to proximal means, first of all, the fingers elongate, then your palm, then your forearm, and then your arm. The same thing happens in the lower limbs as well. So the human growth is cephalocaudal and distal to proximal. Questions can be asked. How MCQ can be asked in super speciality? They may ask you what is correct regarding the growth pattern in humans. 4 options will be there. First option, cephalocaudal, distal to proximal. Cephalocaudal, proximal to distal. Caudocephalic, distal to proximal. Caudocephalic, proximal to distal. Your answer will be A, that is cephalocaudal and distal to proximal. So this is the first thing that you need to remember. But the entire human being does not grow in the same pattern. Different organs grow at different rates. And for that, we have the growth curves defined for 4 major organ systems. These growth curves are called as Scammonn's curves. This is important. You have been reading about Scammonn's curves since long time, since your MBBS days, but probably you don't know that the name of these curves is Scammons curves. So Scammons curves are defined for four major types of growth. First growth is the somatic growth. This is how the somatic growth pattern looks like. So you can put the heading here, somatic growth. It also refers to the general body growth pattern. Somatic growth shows a curve pattern known as sigmoid shaped. So it is a sigmoid pattern which is seen, S-shaped curve. So S-shaped curve, initially in the first 2 years of life, there is a rapid growth, then it becomes a bit stable. It is increasing, but it is not very high. But as soon as 9 to 10 years of age comes and puberty begins, again there is a pubertal growth spurt, so it rises. So rises, becomes stable, then rises again. So this is known as sigmoid growth curve or somatic growth pattern. You may get a visual on this. They may put an unlabeled photograph and ask you which organ system shows it. It is not the organ system, the entire body, the overall somatic growth pattern of any child, of any human being shows this pattern. The second pattern is this. This pattern is seen in patients with brain growth or the central nervous system growth or the neurological tissue growth. Brain growth is rapid in the first 2 years of life. Almost, if you see here, almost 90% growth occurs in the first 2 years of life. After that, only 10% growth subsequently happens. So growth, maturation will continue, but the growth is in the form that initially there is a rapid rise in the first 2 years, then it becomes like a plateau. That is known as brain growth pattern, which is seen as depicted here. The third pattern is something like this. This is a pattern which indicates the growth of lymphoid tissue or lymphoid growth. Lymphoid growth is maximum, if you see here, it is maximum in this period. This is the period from 4 to 8 years. So initially lymphoid tissue starts increasing, then lymphoid tissue undergoes a rapid expansion. This is the time during which palpable lymph nodes even in normal children are very common. And after 8 to 10 years, the lymphoid tissue starts to regress a bit and then it becomes stable and adult values attained. So this type of pattern, growth peak between 4 to 8 years and then becoming static. Some regression happening mainly in the nasopharyngeal tonsils and some pharyngeal tonsils, and the other tissues it becomes static. That is known as lymphoid growth pattern. And the fourth pattern is this. This is the typical growth pattern. It was almost normal till 11 or 12 years, and at 12 years there is a rapid upshoot. Puberty is happening here. So this is the gonadal growth pattern, also called as reproductive tissue growth pattern, which becomes active once the puberty begins. So these are the four growth patterns which you need to know in details, and questions can be asked not only in statement based form but even in visuals. How visuals can be asked? They can put up a photograph like this, combined photograph, okay, and they would label it as A, B, C and D, and they would put, look at the four growth curves shown for a normal human being or a normal human child and identify and mark the correct option. Now 4 options will be given, with each one corresponding to A corresponding to brain growth, A corresponding to somatic growth, B corresponding to this, C corresponding to that. You need to be clear that this type of sigmoid growth curve, this B growth curve, is indicating the somatic growth pattern. This C part is showing your brain growth pattern. D part is showing your lymphoid growth pattern, and peak occurring around 12 years or beyond 12 years of age is the one which is showing a gonadal growth pattern. So this is just a simplified way. This was my perspective of telling you how you should anticipate questions. If you know how to anticipate questions, you prepare according to that. The rules remain the same even in super specialty. Nothing should surprise you. If you get surprised in the exam, you tend to falter and you tend to make mistakes. Now, what are the facts and one-liners you need to remember? Maximal lymphoid growth occurs between 4 to 8 years of age, potential MCQ one-liner. Hormones important in fetal growth. There are 3 hormones which are important for fetal growth. One is insulin, second is thyroxine, and third is glucocorticoids. Remember that although growth hormone is detectable in a fetus, it has little to no role in the fetal growth. So MCQ can be asked to you in super specialty exam. All of the following have a major role in fetal growth except, four options will be given, the odd one out, and the answer will be growth hormone. It has no role in a fetus. And third one-liner, thyroxine secretion in a fetus begins at 12 weeks of gestation. So these are some one-liners mentioned in books that you need to know. Now moving over to anthropometry. Anthropometry refers to the measurement of height, weight, length, and related body circumferences. The first thing we'll be discussing are the weight gain patterns. And in weight gain pattern, the most important, the initial thing we'll be discussing is what happens in the first 3 months of life. To indicate this, now this is a very important and hot topic for your NEET super specialty entrance exams. In the first 3 months of life, let me illustrate with an example. Suppose the birth weight of a child, of a term child, we are talking about a normal term child. Birth weight of a child is X. Okay. Imagine you do the weight on day 3 or day 4 of that. You must have done that. You all are pediatricians. You would have noticed that the weight does not increase in the first 3 to 4 days. There is a loss of weight in the first 3 to 4 days. That weight loss is considered to be physiological. So remember that in the first week of life, first 7 days of life, there is a weight loss instead of weight gain. How much is the weight loss? Varies from child to child, but this weight loss is up to 10% of the birth weight. Up to 10% of the birth weight. So, if I have to give you an example, suppose a child was born at term, his weight is 3 kilograms at birth. So 3 kilograms is 3000 gram. 10% of that will be 300 gram. So in the first 7 days of life after birth, the child may lose up to 300 grams of his original weight. So that is considered to be normal. Between 7th to 10th day, the weight gain becomes predominant, and so the birth weight is regained. And beyond 10th day, true or visible weight gain is seen. True or visible weight gain is seen. And what is the true or visible weight gain? The true or visible weight gain is 25 to 40 grams per day till 3 months of age. All these values you are supposed to remember. So this is the normal growth pattern in a normal term child. Normal growth pattern in a normal growth child. Any variation from this will be a potential MCQ. Now the question arises, why does a weight loss happen in the first few days of life? There are many reasons for that. It is a multifactorial process. First of all, every child, whenever he is in a fetus form, it has a lot of subcutaneous edema or edema fluid is present. So that fluid retention which is there in a fetus, that tends to get lost in the first 7 to 10 days whenever diuresis happens. Secondly, the gain of weight is less than the weight loss which is happening due to this diuresis, this edema loss which is happening. So there is a overall weight loss. Weight gain is happening, but it is not getting reflected in the overall weight of that child. Thirdly, the diuresis is also more. In a child, the urinary concentrating ability is low, particularly low in the tubular function is low in the first few days of life, and so a dilute urine is passed, which facilitates the loss of sodium containing fluid and the edema fluid in that child. Combination of these processes ensure that in the first 7 days, visible weight gain is not there. So beyond 7th day onwards, you find that the tissue growth which is happening, the anabolism which is happening, that starts exceeding the weight losses, the processes, and so visible weight gain starts becoming manifested. This is what we normally anticipate. Now, what are the variations which can happen, and what are the scenarios in MCQ in super specialty which can be asked? Let us take some scenario. Scenario number 1. Then I'll summarize, I'll write it here. Scenario number 1. Term child born at 38 weeks, weight of 3 kilograms. On day 3 of life, his weight was found to be 2.8 kilogram. Is it normal? Think. Yes, it is normal. Why it is normal? Because any weight loss in the first 7 days is considered to be normal. How much? Up to 10%. Here the weight loss is only 200 gram, which is within 10%, and so it is a normal child. Second scenario. So you can summarize it. Any weight loss in unit in the first 7 days up to 10% is considered to be normal. So it is a nothing needs to be done. The answer will be reassured that nothing needs to be done. Second scenario. Child born at term, birth weight 3 kg. On day 3 of life, weight found to be 2.4 kilogram. Now weight loss has happened, but how much weight loss has happened? 600 gram. If you apply basic mathematics, it is 20% of the weight loss. This is not normal. So if there is any weight loss which is excess, any excess weight loss more than 10% in the first week is always abnormal. And what is the most common reason for this? It occurs due to dehydration. And the cause of dehydration will be less feeding of the child. Exclusive breastfeeding is not proper, so you would increase the feed of that child. So that is the second scenario which can be asked to you in entrance exam. Third scenario. Child was born at term, weight is 3 kilogram, but on day 3 of life, weight found to be 3.5 kilogram. Layman would be okay. Layman would think, okay, child is gaining weight. But you know, child should lose weight normally in the first 10 days. If there is excess weight gain happening, and that too 500 grams, you should think of fluid retention in the child. So any abnormal weight gain in the first week of life will always be considered to be abnormal. I am giving you practical real life scenarios, how questions are asked, how questions can be asked in fellowship and super specialty exams. This is not something we read in NEET PG level or in while doing our residency, but these are practical problems and questions are asked based upon that. So abnormal weight gain will indicate fluid retention in the child. The most common cause of fluid retention in a child in the first 7 days, most common cause is congestive cardiac failure. And if I have to ask you what is the most common cause of congestive cardiac failure in first 7 days of life, there can be multiple reasons. Commonly occurs due to a reason called as patent ductus arteriosus. A large PDA can cause excess or abnormal weight gain in the first week of life. So these are the 3 scenarios, the practical application of the normal weight gain pattern in the first 3 months of life. Now what happens beyond 3 months? Beyond 3 months, we are supposed to use formulas known as Week's formulas. We use formulas known as Week's formulas. So you must have read about these formulas. We'll summarize them here. If the age of the child is between 3 to 12 months, if age of the child is 3 to 12 months, the weight in kilograms, the expected weight or ideal weight of in kilograms is given by the formula age in months plus 9 divided by 2. If the age of the child is between 1 to 6 years, the expected weight is given by the formula age in years multiplied by 2 plus 8. Do not forget the bod mass which you have read in your 6th or 7th standard. And third is your 7 to 12 years. Expected weight of a child is given by the formula age in years multiplied by 7 minus 5 divided by 2. So you will apply these formulas and you will calculate the ideal or expected weight at a certain age. In your clinics, in your long cases, in your malnutrition cases, you have already done this. So this is just summarizing what you have already known. Now, what are the ready reckoners for weight? If you know the birth weight at a certain age, you can tell the approximate weight at a given age. So if the birth weight of the child is X, at 5 months of age, the weight becomes 2x. At 1 year, the weight becomes 3x. At 2 years, the weight becomes 4x. This is something you already know, but questions can be asked on this and we'll discuss how questions are asked. At 3 years, the weight becomes 5x. At 5 years, the weight becomes 6x. 7 years, the weight becomes 7x. And 10 years, the weight becomes 10x. So this is considered to be the ready reckoners of weight shortcuts if you know the birth weight of the child, and provided you assume that the child is growing normally. So question can be asked in indirect way. Doubling of birth weight occurs at what age? 5 months. Tripling of weight occurs at what age? 1 year. Quadrupling of birth weight occurs at what age? 2 years of age. So this is how questions, one-liners, can be asked in super specialty exam. Now what are the examples of complicated questions which can be asked to you? Question can be asked to you like there was a question asked in one of the entrance exams. Calculate the percentage gain in weight at the end of first year of life. And the options given were 50%, 100%, 200%, and 300%. Now, many of the good students I know marked this question wrong because they were not careful enough. In MCQs, you have to be careful what you are marking. Sometimes question looks very easy and we immediately mark it. We know that birth weight is X, and at 5 months it becomes 2x, at 1 year it becomes 3x. So what is the gain in weight what is the weight at the end of first year? It is 3x. But question is asking percentage gain in weight. So gain will be 3x minus the original weight at birth, that is 2x. So what is the percentage gain? It will be 200% and not 300%. One of the very good students and one of my juniors marked it as 300% and immediately repented when he came out of the exam. Of course, we had a talk later and he told me about it. So this is a common mistake which people make. So answer to this question is 200%. So this is an indirect way of how questions can be asked in super specialty and fellowship exams based upon the ready reckoners we discussed. Moving over to the height and length gain pattern. You know that in a lying down child, we use the term length. Once weight bearing begins, we use the term height. So what are the normal pattern? At birth, the normal length is approximately 50 centimeters average. At 1 year, it becomes 75 centimeters. At 2 years, it becomes 85 to 90 centimeters. And 4 years, it becomes approximately 100 centimeters. So if you see carefully, doubling of birth length occurs at 4 years of age. Doubling of weight occurs at 5 months, but doubling of birth length occurs at 4 years of age, that is 100 centimeters. And there is a Weeks formula here as well. So what is the expected height in centimeters for age between 2 to 12 years? So expected height, the formula is given by week in the form of age in years multiplied by 6 plus 77. That will be your expected height between the age group of 2 to 12 years. What are the height velocity patterns? These are one-liners and you are supposed to remember. In 0 to 6 months, the height centimeter gain is 16 centimeter in 6 months. Between 6 to 12 months, it is 9 centimeters in 6 months. Every 6 monthly. 1 to 2 years, now it becomes a yearly thing. So 12 centimeter per year. Between 2 to 5 years, it is 6 centimeter per year. 5 to 10 years, it is 5 to 6 centimeters per year. So these values, they are one-liners for your entrance exam. You have to cram them up. You have done that in the past for your practicals. Now you need to do it for your super specialty exam also. Now, what is the target height according to parental height? It's a simple thing. It's a formula-based thing. The target height depends upon the mean parental height. So how do you calculate according to that? Target height in case of males, it is calculated as height of the father in centimeters plus height of the mother in centimeters divided by 2 plus 6.5. In case of females, it is the same, but you minus 6.5. This is the target height formula. Now moving to the upper segment and lower segment ratios. What is the upper segment? The part from crown of head to midpoint of pubic symphysis is considered to be the upper segment. From midpoint of pubic symphysis to the sole of foot is called as lower segment. Upper segment is also sometimes called as sitting height. So when I am sitting here, the part of my upper torso which is visible roughly corresponds to upper segment. So upper segment to lower segment ratios, normal values are sometimes asked in exams. You know that in you and me, the lower segment is larger, upper segment is slightly smaller. But in a child who's just born, the upper segment is much larger and lower segment is smaller. So at birth, the upper segment to lower segment ratio is 1.7:1 to 1.9:1. At 3 years, the ratio becomes 1.3:1. Between 6 to 7 years, the ratio becomes 1.1:1. And 8 to 10 years, the ratio becomes 1:1. This is very, very important. Many guidebooks go wrong in this. Even many people who read the textbooks, they take it wrongly. In one of the guidebooks for super specialty, it is mentioned that ratio of 1:1 is attained at 7 years. That is absolutely wrong. You are advised to read 4 texts. First, you read Nelson. Nelson 21st edition says, ratio of 1:1 is obtained beyond 7 years of age. At 7 year and beyond 7 year are not same. O.P. Ghai, IAP textbook of pediatrics and Suraj Gupte, all these textbooks take a value between 7 to 10 years, 8 to 10 years and so on. And so the better answer for your entrance exam, if this question is asked, is 8 to 10 years. 8 to 10 year value is mentioned separately in 2 different textbooks, one Indian and one foreign author as well. So 8 to 10 years is the time during which 1:1 ratio is attained. And beyond 10 years, the adult ratios are attained. What is the adult upper segment to lower segment ratio? In you and me, it is 0.9:1. Sometimes 0.9:1 is also written as 1:1.1. So different ways of saying the same thing in MCQ entrance exam. Having knowledge is one thing. Without knowledge, nothing can be achieved. But application of knowledge is an art. That is why MCQ solving is an art. I know a lot of good people, excellent people who don't do that well because they haven't practiced MCQs. And on the other hand, there are people who may be having some deficiency in knowledge, but their MCQ solving skill is so good that they perform excellent in MCQ entrance exam. Super specialty FNB exam, you need to strike balance. Knowing the theory is absolutely fine. All of you are MD, great residents you have been, but now is the time to focus on MCQ oriented approach, and that is what we in this module, all these modules I am targeting on. So 1:1.1 is another way of saying 0.9:1. So this is the normal upper segment to lower segment ratio. Abnormalities, infantile proportions and short statures and disproportionate short statures will be talking in the separate segment. Now talking about head circumference. When you take head circumference, how do you take it? When you calculate head circumference, first it should be a non-stretchable measuring tape. In a non-stretchable measuring tape, you pass it through the upper part of the head just above the supraorbital ridges. So these are the supraorbital ridges from where it passes. At the back, it should go through the maximum diameter covering the occipital protuberances, because that is where the maximum diameter is. So you part through that and then you come out, and usually it is measured just above one of the supraorbital ridges. So you circulate it like this, bring it here and then calculate here. This is the easiest way and the recommended way of calculating it. When you calculate head circumference, it gives you a lot of information. So head circumference, I hope you know, it is also known as occipitofrontal circumference, because it is occipital and frontal areas that are being measured. So what is the normal HC or normal OFC? In a term neonate, the normal value is 33 to 35 centimeter. Different values are seen in different populations, because it is something which is determined racially as well. What is the Dine's formula for head circumference? Now, Dine's formula is something which is there in the clinical manuals but often forgotten when you prepare for exam. Dine's formula says head circumference can be calculated roughly from the length of the child. It says that head circumference is given by the formula length of the child divided by 2 plus 9.5. This is the median value. Okay, and then we put a value known as plus minus 2.5 to tell you the range of the child. To give you an example, this formula says, suppose the length of a child is, say, 70 centimeter. Okay, 70 centimeter. So 70 by 2 will be 35. 35 plus 9.5 will be your median value of your head circumference. So it will be 44.5 centimeter. Plus minus 2.5 will give you the range for that normal child according to that length. So this is known as the Dine's formula for head circumference, which you are supposed to remember. This formula is important for your entrance exams. And what are the normal head circumference gain pattern? One-liners. 1 to 3 months, it is 2 centimeter per month. 4 to 6 months, it is 1 centimeter per month. 7 to 12 months, it is 0.5 centimeters per month. 1 to 3 years, it is 0.2 centimeter per month. And 3 to 5 years, it is 1 centimeter per year. It becomes slow. So this is the normal OFC gain pattern. Now, question, MCQ can be asked. Calculate the expected head circumference at 6 months in a normal child. Now, how you are going to calculate it? For calculating this, you need to know these gain patterns. Okay. So, how would you calculate expected head circumference? So, expected head circumference, let us take the value. What is the normal value? The normal value at birth is, we just did, in Indian setting, it is 33 to 35 centimeter. Right? 1 to 3 months, the gain pattern is 2 centimeter per month. So 1, 2, 3 months. So 2 centimeter per month will be 2 multiplied by 3, that is 6 centimeter will be gained. Then 4 to 6 months, 4, 5, 6, 1 centimeter per month. So 6 centimeter will come first, then another 3 centimeter will come. So total you will add 9 centimeter to this. So total gain at the end of 6 months will be 9 centimeters. So what will be the expected head circumference at 6 months of age? You add 9 to this, it will be 42 to 44 centimeters, and that will be your correct answer. So answering question like this, you need to know these gain pattern values which I have mentioned here. Difficult question. It is not an easy question, because options will be 40 to 42, 42 to 44, 44 to 46, 46 to 48. They will tell you the normal value at birth. They will. If not, this is the value you are supposed to remember. And then you will have to apply this gain pattern and then reach the correct answer. They look easy, but they are tricky when actual exam question comes. Now, what is the relation of chest circumference to head circumference? You know, in you and me, the chest circumference is larger, the head circumference is smaller. But in a child, the head is larger and the chest is smaller. In a normal child, In a normal child at birth, the head circumference exceeds chest circumference by 3 centimeters. Normally, it may be 2.9 also, it may be 3.1 also, but normally it is seen that in a normal term child at birth, head circumference exceeds chest circumference by 3 centimeters. At 9 to 12 months, head circumference becomes equal to chest circumference, and beyond 12 months, the chest circumference exceeds head circumference, just like you and me. So this is a MCQ. This is MCQ. When does head circumference become equal to chest circumference? If a single value is mentioned, answer will be 9 months. If a range is asked, answer will be 9 to 12 months. And when does chest circumference exceed head circumference? It will be beyond 12 months, that is beyond 1 year of age. So these are the two MCQs that you need to remember. If somebody asks you, where do you practically measure? Practically, we measure in a child at the level of nipples, which corresponds roughly to the fourth intercostal space in a child. So roughly at the level of nipples, going back using a non-stretchable tape and going horizontally, not vertically, not angulated. You go back and then you measure, bring it down and again measure at just laterally to one part of the nipple. This is how you measure it. You pass it like this from the back, you bring, this is the nipple and this is where you measure it. So this is how you're supposed to measure chest circumference in a child. Nobody will ask you, but trust the examiners for asking stupid and unaskable questions sometimes in your exam. So this is regarding the chest circumference. Now potential MCQs can be asked on this. What MCQs can be asked? In a child aged 15 months, the head circumference is still greater than chest circumference. What is your interpretation? If the head circumference is more than chest circumference in a more than 1 year old child, one possibility is protein energy malnutrition. You need to rule out PEM and you also need to rule out macrocephaly in the child. So rule out PEM, rule out PEM will mean the chest is very small and macrocephaly will mean the head is too big. Occipitofrontal circumference more than +2 standard deviations of the mean is macrocephaly. So you will rule out both these two conditions. Another scenario. In a day 1 child, head circumference exceeds chest circumference by 6 centimeter. What is your interpretation? Normally it should exceed by 3 centimeter. Here it is exceeding by 6 centimeter. Much larger head, much smaller chest. So what are the two possibilities? Again, two possibilities you can consider. First possibility, the head is too big. So there is rule out hydrocephalus. It is a just born child. Second possibility, too shrunken chest. Head may be normal in size, chest is shrunken, which will be seen in asymmetrical IUGR. More about IUGR we have discussed in a separate module. So these are the possibilities. If it is a day 1 child, you would think on these lines. If it is a older child and this value is given, simply this value is given, then these are the possibilities you need to consider. So these are two MCQ scenarios for super specialty exam that you need to add. So we have talked about the normal anthropometric patterns, normal growth and development, and just touched upon some of the abnormal values. In the subsequent modules, we'll be talking about the abnormal things, the abnormal nutrition and abnormal stature, height and chest circumferences.